Today we're going to talk about a nice framework or a good diagnostic approach for vertigo. Vertigo sometimes can be confusing if we don't approach it well. So vertigo is the illusion of motion, right? And something to keep in mind in history taking is that always anyone will ask whether it's worse with movements, worse with positional change and all. So ask specifically whether it's triggered or whether it's worse with head movements. The reason I'm saying it, because if you're having postural hypotension, so if you get up suddenly, if you have a certain positional change, they can have dizziness and they could interpret and say sometimes it is vertigo as well. So that's why specifically asking, just to avoid that, whether head movements will make it worse. Right. Now, diagnostic approach is that we divide our approach, we divide the vertigo, we divide these vestibular symptoms to three main groups. And the first one is acute vestibular syndrome. The second one is episodic vestibular syndrome. And the third one is chronic. Right. Moving on to the acute vestibular syndrome. So this is acute onset vertigo or acute onset vestibular symptoms that are persistent, that is lasting, right? That is not going away. So two main things to consider here. First one would be vestibular neuritis, right? So this is the inflammation of the nerve. It could be viral, likely from herpes simplex, and usually this is not associated with hearing loss. So I think I would just put ear is okay, right? So these people will have severe vertigo, these people will have nystagmus, and importantly they will have abnormal head impulse test. Now, the head impulse test is something that you should know. So read about it, watch a video of how to do it, and then you'll understand it. In simply, you move the patient's head, and then before you move their head, you ask them to fixate their eyes on your nose or something. And then when you do the movements, their eyes should remain fixated on your nose. So that is a normal head impulse test. And then if they can't do that, if their eyes deviate and then quickly corrects back to your nose, that's an abnormal test. It's called the corrective saccade, right? So an abnormal head impulse test is suggestive of peripheral vertigo, like peripheral cause for vertigo, right? And the second one that can cause acute vestibular syndrome is a big one, and that is stroke, right? So posterior circulation stroke. Right. So these people will have stroke symptoms. They have risk factors for stroke. They would have significant ataxia. They could have other cerebellar signs and all. And something to note here is that the HINTS test, HINTS test. So that is HI is head impulse, which we already talked about. The other one is direction changing nystagmus. And the other one is test of skew. So in the HINTS test, if one of these is positive or one of these is abnormal, that is very concerning for stroke. It is said that this has higher sensitivity than an MRI with diffusion at the early stages. But that is if it is done by the right person on the right patient. So you should be an expert how to do it. And secondly, it should be only done to people with acute vestibular syndrome. So if the symptoms are episodic, don't do it. Only for acute vestibular syndrome. All right, so moving on to the HINTS test. The first one is head impulse. So we already talked about it. If it is abnormal, that is likely to be peripheral. But if it is normal and the patient is having acute vestibular syndrome, then you're concerned for a stroke. And the second one is nystagmus. So when we talk about nystagmus, we have to talk about direction changing nystagmus. Why are we talking about direction change in nystagmus? So it is when we are looking, so what is direction change in nystagmus? It is when you are looking to the right, the nystagmus might be to the left, and then when you're looking to the left, the nystagmus might be to the right. So it's a direction change in nystagmus, and that is concerning for stroke. So the type of nystagmus that you usually get in peripheral vertigo is that if it is a unidirectional nystagmus, that is likely to be peripheral. Okay, so direction change in nystagmus is concerning for stroke. And the other one is the test of skew. Now that is a vertical misalignment of your eyes. You can do the cover and cover test and then you can figure that out. So that is concerning for stroke. Right. Okay, now we're going to move on. The next part of the talk is that we're going to move about, talk about the episodic vertigo, right? So when talking about episodic vertigo, we again, what is episodic vertigo? You're having an episode of vertigo, or you're having the vestibular symptoms, and then you recover from them completely, and then after some time you get them back. So that is episodic, right? Again, we'll divide it into two main areas. The first one would be spontaneous episodic vestibular syndromes, and then the second one would be triggered episodic vestibular syndromes. So the spontaneous ones would be your vestibular migraines and then your Meniere's disease, right? So the vestibular migraines, it will have the migraine history and the features of migraine, and then the Meniere's disease would have a lot of ear symptoms, ear fullness, tinnitus, hearing loss, things like that, right? And then moving on to triggered episodic vestibular syndrome, that is the one that we all know, that is BPPV, right? So that was easy. And I'm not going to go into huge details about each one, but I just mentioned some points that would help you to build your knowledge on. And then lastly, about chronic vestibular syndrome. So the differential for this are vast. Again, you can subdivide this into central nervous system issues. So this should be your chronic cerebellar pathologies. And then this could be due to something with sensory, that is your issues with proprioception. And then this could be a default issue or like a primary issue in the vestibular system as well, right? And what's mostly important is the acute vestibular syndrome and the episodic ones. So what we talked about was that in the acute vestibular syndrome, that is where symptoms are acute and persisting, two main differentials, vestibular neuritis and stroke, and we talk about the Hint's test, head impulse, nystagmus, and test of skew, and we talk about when to do them and how to do them as well. And secondly, we talked about the episodic ones. Again, we subdivided into spontaneous and triggered. The spontaneous ones were the migraines and the Meniere's disease. Meniere's disease is always associated with, most of the time it's associated with all the ear symptoms, the hearing loss, the tinnitus, the fullness, and then the triggered ones would be the BPPV. And of course, the chronic vestibular syndrome, so the chronic vertigo, it could be central, sensory, or vestibular, and then the differential of that are many. So if you use this approach when you are assessing someone with vertigo, it would make your life easy. And then just read on the test, the head impulse test and the Hint's test, which is quite important.